Well, good afternoon, everyone. We do have a good number of colleagues who've joined us, so we will kick off the proceedings formally. So a very warm welcome to everyone. I'm Chris Burton, Professor here at the University of East Anglia and Dean of the School of Health Sciences. It's my very great pleasure to chair this afternoon's webinar on driving innovation and knowledge exchange. Of course, the organisations that comprise the Council of Deans of Health do play such an important role in developing our future healthcare workforce. We also, of course, contribute to developing new knowledge, research to drive policy and practice. But increasingly, I think our sector are working across organisational boundaries to really drive innovation and change and absolutely add value to our health systems and the wider economy. So I think it's fantastic that we've got a webinar this afternoon, absolutely focusing on how we can and have been working in partnership to drive, as I say, both innovation and knowledge exchange. We have three speakers who are joining us. Each speaker will present for roughly 10 minutes. And then we will have an opportunity for questions from colleagues on the call. But let me, I'm sure they will introduce themselves fully when they do start their slides. But just to let you know, in the room, in the webinar rather, we have Nicola Walsh. Nikki is Professor of Knowledge Mobilisation and Musculoskeletal Health at the University of the West of England. We have Yanis Papas, who is Professor in Public Health and Integrated Care, and also Director of the Bedfordshire, Luton and Milton Keynes Integrated Care Research and Innovation Hub, hosted at the University of Bedfordshire. And Rebecca Howling. Becky is Research Portfolio Officer, NHS Bristol, the North Somerset and South Gloucestershire ICB. So I know I've already had a very quick preview of the slides, that we've got three really good presentations that will absolutely help us to consider these issues in the round. So without further ado, I'm going to invite Nikki. Nicola, if you'd like to share your slides, and the floor is all yours.
Thank you very much. And hopefully you should be able to see my slides. Is that correct? Perfect. Thank you, everyone. So, yeah, as Chris said, I'm Nikki Walsh, and I'm from the University of the West of England in Bristol, but I also have a role within Bristol, North Somerset and South Gloucestershire Integrated Care Board, and also just want to acknowledge Paul Roy, who is the Associate Director of Research, because I'm going to talk about an initiative today that we've both kind of co-developed. So what is our Impact Accelerator Unit? In effect, it's a collaboration between our two local universities, so UE Bristol, the University of Bristol, and our local NHS Integrated Care Board. The unit itself is it's a staffed unit, so it has a manager and it has multiple staff contributing to the running of the unit. And importantly, it's a unit that's embedded within the Integrated Care Board. So I'll go on to talk about this a little bit later, because some of you may be aware of different models of Impact Accelerator units. It works across the partners to identify meaningful research, so real-world questions that are likely to have an impact on health and care delivery. And if in effect, it facilitates the best use of available evidence. I put this picture of a rickety old bridge there, because what effect the Impact Accelerator Unit does is it bridges that gap between the NHS service decision makers and planners and academia. And that's a really movable, unstable, unsteady place to kind of be and to work in. So things aren't simple, get very messy and very complicated. And the whole purpose of the IAU is to try to make that, I guess, a little bit more of a stable place to do our work. The purpose. So as I suggested, what we're really looking to do is to facilitate the use of the best available evidence and to inform kind of decision making and planning. So obviously our Integrated Care Board seeks to plan services for the local communities And we hope that that is based on the best evidence available, both from within our region, but also we look to evidence generated outside our region as well. In addition, we work across academia and with people within service delivery, with patients and the public, and with the service planners to really identify those important real-world questions. And then we co-create research seeking to address those questions. What we think, and we hope that does, it expedites the impact of research evidence. So we always hear banded around, it takes 17 years for research to get into practice. Actually, we've got evidence when it takes just a few months from that research becoming available to it being embedded into practice. And we, of course, hope that all of that improves the quality and efficiency of health and care delivery, patient and staff experience, ultimately outcomes for patients and the services themselves, both at clinical and cost level. But also it helps to support our universities to evidence impact, something that we often find quite difficult and aren't necessarily that good at doing. So we have a funding model. So our two local universities have invested not a large sum of money to effectively pump prime the Impact Accelerator unit. So our funding model is effectively the two universities have provided money to pump prime the start of the initiative. What we also look to do is we host many research grants through NIHR within our NHS ICB. And within that, we cost 5% of a Band 8A through the duration of the grant to actually supplement the work of the Impact Accelerator unit as well. That therefore allows us to fund the IAU. And what that does is it funds NHS activities to support the use of evidence and embedding evidence into practice, and also a manager of our Impact Accelerator unit. But the good news for the universities is that the funding for the universities decreases over time. So whilst we request funding from our universities to pump prime the start of the Impact Accelerator unit, we're now in a position where over a 5-year period, that has reduced on an annual basis because the income from our NIHR grants are actually starting to supplement the continued running of the unit as well. So why is this model really important? So I said before that we've got an Impact Accelerator unit that's embedded within our NHS ICB. And in other areas, you may be aware of Impact Accelerator units being embedded within universities. However, the really important part of trying to influence the organisations that make the change is that they're looking to pour evidence in. So you're already pushing against an open door. There's also, if you're trying to influence from within, a good understanding of this really complex system that the NHS happens to be. We also internally possess that tacit knowledge, that real understanding of how systems really work and who those people might be that we want to talk to. We're also really aware internally of what the evidence needs are at the time. I've suggested this is a continually changing environment, and it literally does change from week to week as to what priorities might be. It also provides us with direct access to routinely collected data and our system-wide integrated care set, so we can really evidence what changes are actually happening and the importance of strategies in real time. We also speak a shared language. We all know that within our own institutions, we use language that is often inaccessible to anybody else, and this can often create a barrier in itself to the use of evidence. So we create that shared language. If we try to evidence from within, we also have this legitimacy. We're not an external agent who's going to another institution to try to influence change. We're actually influencing change from within that institution itself. And therefore, we have the opportunity to land that evidence in the right place and with the right teams. We also really understand the importance of timing. The evidence might be exactly the right thing that the ICB wants and needs, but it just might not be the right time. And you only really know that if you are embedded within a system. And then finally, we can really work with academics to shape that evidence for local use, because we always know that the context of where you're wanting to deliver something will influence how evidence is used. So just some very brief ideas of some of the impact that we've had so far. So we've embedded evidence that's been produced locally around how to manage prosthetic joint infections. We've got evidence embedded on managing dementia diagnosis in people from South Asian communities. We've embedded into EMIS how to undertake inflammatory marker testing, so GPs aren't requesting lots and lots of different tests through some very simple changes on EMIS systems. We've also embedded our local evidence to a wider range through the Arden system, which is a national network that GPs access for information on how to manage patients. And there are multiple more of these, but I thought I'd just give you an idea of the few of them. So whilst it's still a relatively new initiative, we have already had impact on patient outcomes and also cost savings within our system, and are able to support our universities in evidencing the impact of their work. So if you'd like to know more about our IAU, then please either email me or directly email the Impact Accelerator unit itself. And my apologies again for my computer crashing.
Don't worry about apologising, Nikki. Just good that we managed to get you back on screen, but thank you for that really interesting presentation. Lots there for us to think about in terms of the embedded nature of the work that you're doing and how that may add value and make things easier. Yanis, I'm going to invite you to share your slides next, if that's okay, and please feel free to introduce yourself again to everybody on screen.
Yeah, I believe you see this.
Yeah, we can see the slides, and now they're in present of you.
Okay, brilliant. Well, good afternoon. Thank you very much for the invitation. I'm Yanis Papas, professor in public health and integrated care with the University of Bedfordshire and the Faculty of Health and Social Sciences. I work closely with our executive dean, Dr. Alison Tressiter, who I believe is somewhere here today. So as most of us in this room actually know, the ICSs were given a series of very important mandates, with the main one to actually place emphasis on integration, collaboration, and partnerships to create a more joined-up approach to providing health and social care. And they were expected actually to achieve this via several means, including their own commissioning practices. The current commissioning and organizational landscape, or at least for now, involves 42 integrated care systems that were established across the country, responsible for the planning, organizing, commissioning, and monitoring of health and social care. The integration of care is, of course, quite a sensible way to organize services, especially if you think that when we're asked to put a fight against the common enemies that we have, inequalities, obesity, diabetes, CVD, mental health, and other complex social issues, we probably stand a better chance to be successful if we work in partnerships rather than individual hospitals or primary care practices or universities in that respect. However exciting this initial stage of organizing the ICS's framework may have been, it was also a significant challenge, mainly for the integrated care boards, as the mandate they received included the expectation that commissioning follows research evidence. But the mandate was actually delivered without substantial guidance or the budget to support the development of the evidence itself. In the University of Bedfordshire, we actually recognized this early enough, and we recognized that this is a very significant challenge for the ACBs. But it was also a more significant opportunity for the universities, for our university and the faculty. So this realization coincided with the NHSC's decision to make funds available for universities to become anchor institutions to ICBs and work with them on developing local and regional research and innovation agendas. So our faculty was successful with securing funds for the NHSC to support the BLMK ICB with developing their own research and innovation agenda. So to do this, we have established a National Center of Excellence in Integrated Care Research and Innovation. The BLMK ICS Research and Innovation Hub, as we call it, hosts 17 projects. All of them are implementation programs across the first three areas or pillars that you see on your screen. Our agenda is varied and was developed with two principles in mind. The first one was to support a local ICB to develop evidence-based policies and practices. And the second one was to address inequalities in the provision and uptake of care. Of course, this work broadly corresponds to the areas of inclusive workforce, new ways of working, safeguarding children and adults with complex needs. Our work has practical value to a range of stakeholders. We developed a knowledge base to address health and care inequalities. We are engaging patients with their own care, and we provide a roadmap for the development of a more competent workforce. We are also working towards devising a simpler, more integrated response system for people who experience complex social care needs. At the strategic level now, the hub has placed the university and the faculty in the epicenter of a network of hospitals, 95 primary care practices, 27 primary care networks, 4 local councils, and countless volunteer organizations in Bedfordshire, Luton, and Milton Keynes. Why is this of interest? Of course, universities working with local stakeholders is barely a novel concept, is it? And we recognize this, but we also recognize that our approach to involve the ICB as joint partners and having a joint governance was actually a game changer. And we are ready to be, to be quite loud about this. So we established a roundtable approach from the beginning to to develop our implementation and research agenda, and all 17 studies were actually designed to make a practical impact to ICB priorities and therefore to the population that we serve. Finally, and I will bring this section to a close, the hub is quite central in quite a few exciting developments that have strategic significance for the university. We were a strong proposing asset in our successful ESRC doctorate training partnership application with Cambridge, Anglia Ruskin, and Suffolk. Other work that we do in the hub is also central to the health and social care related objectives of the civic agreement that we have with Luton Council. And I believe it will also be for a civic agreement that we're actually preparing with Bedford Council. Our faculty is also one of the founding partners in the development of the EPIC, which is the East of England Partnership for Innovation in Integrated Care, which actually brings together a very significant pool of knowledge from 6 universities and 5 integrated care systems, serving about 6.5 million people. And I will leave you with this beautiful picture here, as I'm delighted to actually say that last week we received our first international recognition as we were presented the 2025 International Conference in Integrated Care Partnership Award. The award was presented for a community targeted outreach program, or we call it CTOP, which is transforming or tries to transform the approach to health and social care workforce development. So Professor Nazrin Ali, that you actually see in the left of the picture there. So her and her team are actually working to attract, recruit, and retain the best talent from across the region, especially from disadvantaged communities, to boost their aspirations and open doors for them in careers in health and social care. To give you an understanding about how important this award is, at least to us, this is the conference that it's very difficult for anyone who does any important work in integrated care around the planet not to attend every year. Hundreds of organizations were attending, with the usual suspects from Canada, from the United States, from Central Europe, including several commercial organizations that are involved in this sort of research as commissioners, funders, and but also as innovation hubs. I will leave you with this today, and many thanks.
Many thanks indeed, Yanis. A very different perspective. Thank you very much. I'm sure that's going to generate lots of questions as well. So we've gone from impact or accelerator unit to anchor institution. I'm now going to invite Rebecca Howling, to provide a very different perspective on our focus on driving innovation and knowledge exchange. So over to you, Becky.
Thank you. Hi everyone, I hope you can see my slides. Yeah. I've just switched to, can you still see them in presenter mode? Great, thanks. So yeah, hi everyone, it's great to be here today. So yeah, my name's Becky, I'm a Research Portfolio Officer and I am based at the Bristol, North Somerset and South Gloucestershire Integrated Care Board, and I'm going to talk a little bit today about researchers in residence. So just for a quick bit of context, as an NHS active, as a research active NHS organisation, the ICB is eligible to receive research capability funding. We do lots of things with our research capability funding, and one of them is the researcher in residence placements. So you might be familiar with them as embedded researchers, but the idea is that it's a university employed academic or perhaps university supervised academic placed within a non-academic setting for a discrete piece of work or an evaluation or a service provider to develop a clear objective, something that's been set previously, and working together. It's seen as an increasingly powerful way to link research and researchers with practice and practitioners. So the idea is a researcher within a service. I've included a couple of links at the bottom of the slide. There's a website for all about embedded research, but also a really nice summary was on the University of Plymouth's webpage. So I've just included a link here, but they had a nice quote on there that it was about creating balance between research and evaluation and relevance and rigor. I've also got in quotes here, the idea is that it breaks the model breaks the ivory tower and places researchers directly within real world contexts where their work can be applied directly. I also wanted to highlight the breadth of the areas. So as I can say, these are the ones that the BNSSG ICB has facilitated. So just to highlight that when we say services and bringing researchers into services, it's not only the Integrated Care Board. We have had some researchers placed within the ICB, really successful pieces of work. But we also have supported some with Serona Care and Health. I've put a link to their page here. We had one with the Self-Injury Support Organisation. So we facilitated an academic to be placed within the organisation as they had some KPI data that they wanted to be reviewed, and they also wanted to have some interviews done to look at their services and how they could improve them. We've also had one placed within the Bridge, which is a sexual assault referral centre. I'm going to highlight a little bit more about that one in a second. And the Care Home Hub. The Care Home Hub is a collection of care homes that were working closely together within the west of England, and they wanted to try a new model of a hub, so working as a network. I've included the webpage here where they talk about, they call it Same Scrubs, Different Organisation, and they wanted to employ a researcher to look at the model to see how successful it was, to look at how it could be rolled out in other parts of the country, thinking about the areas where it was working really well and if there was any barriers to it being rolled out in other parts. So this was just to highlight what the model is and just that we work with lots of different organisations where we can. There's lots of benefits to the model. I've highlighted some here. I won't go through each of them just for time, but we wanted to highlight that whilst there are shared benefits, we've also had feedback from the academics that we've worked with and the system partners that there's also lots of individual benefits. So just to highlight one or two of these, we have had feedback that it facilitates the co-production of research. So this is what we were talking about on the first or second slide, where the academics can come into the services and co-produce what that research is going to look like and what the service really needs at that time. We've had feedback from the academics that have been placed that they've had access to data that they might not normally have had access to, but also it's quite timely data, and they're often working with the teams who have directly collected that data themselves. So it's just really valuable and opportunity for that rich environment to be working together in. And then some benefits to the system. So the service provider can fill a skills gap. So for example, we worked with one, I believe this was an integrated care board colleague who had done lots and lots of interviews with patients, and they had really a wealth of data, and they just wanted some support from an academic with the analysis. So it was just about looking about in their team, what are we hoping for, what don't we have, and then seeking an academic who could meet their needs and work with them really well on that. So again, just to highlight, there's lots and lots of benefits, but some to the academic as well and some to the system. I'm going to highlight a few more to the academic in a second. Because I wanted to show a couple of real world examples. So I mentioned the Dr. Merrick, who is based at the University of West England, who worked with the Bridge, which is a sexual assault referral centre. So I've included a link to a blog post about Dr. Merrick's work and being announced as a researcher in residence. What they were working with at the Bridge was they were working to put patients back at the heart of redesigning their care. And they also wanted to look at some barriers to care, excuse me, that were happening at the time. And whilst that was all happening, and it was a really valuable piece of work, I wanted to highlight some of the outputs that followed that work. So the team are presenting early work on the adult sexual health patient pathways at a conference in Coventry this June. Dr. Merrick is supporting bidding for a funding submission from the SARC for pathways for clients with complex needs, and supported a range of staff research efforts. So again, we're seeing those research efforts continue past the end of the discrete researcher and residence placement. And lastly, the team is running a UE-funded impact project around survivors redesigning their sexual health. And they're also going to be presenting their findings at another network within June. So whilst we just wanted to highlight that whilst the placements themselves are really positive and a lot of great work happens, there's also tends to be a lot that comes out of it. And we think that one of the reasons that so much more can come out of it is because with the research and residence placements, there's space to be quite flexible, or as flexible as you can be with how they're working and how the placement is going to look. Very similarly, I just wanted to highlight, so this is in relation to the R&R placement that we had with the Care Home Hub. So as I mentioned a couple of slides ago, Anne Smith, who's another researcher, coincidentally from the University of West England, was placed within the Care Home Hub to evaluate the successes of the model of the care homes all working together. And they also had more work that came out of this. And one was a piece of work looking at having protein for breakfast. So the care home residents making sure that they were eating protein for breakfast and then seeing what happened to their sugar levels throughout the day. And they took this poster that I'm showing, it's got the names of the researchers and Pam at the top, who they took this to a conference, I think late last year, and they won best best poster within primary care for this piece of work. So I won't go through it all now, but I just wanted to highlight all of the work that comes out of the placements, as well as the initial planned objectives and work. I also wanted to highlight a few enablers of successful projects. This is definitely not an exhaustive list, but this is just some of the things that we've found out over time that really help to make sure the research and residence placements are as successful as they can be. And one of those is having clear objectives set at the beginning. So I mentioned one of the benefits that we think is about being really flexible with the placements. And whilst we always want to give space for more work to develop, we found that it's helpful to have clear objectives from the outset so that the academic and the services, if they have their goals that they're looking for to be met, that it's just clear from the outset, and they all know what they're working towards. Another one is pooled budgets. So this isn't a set rule, and when the applications come in for services that would like to work with an academic, we'd review all of them, because sometimes it's just not possible for the service themselves to have budget available to pool with the RCF budget that we can contribute. But we have found that it often leads to successful projects, perhaps because there's buy-in from both sides. But that's just something that we wanted to highlight, as we've seen a good indicator. We've also, one very important one is the commitment to including the academics in working groups or current meetings that we know are happening. So if a service comes to us and says they would very much like to work with an academic for a piece of work, say that's fantastic, but could you show us and tell us what working groups, what meetings, what events you've got set that they would be able to be embedded within, because we found that just having that from the outset and just knowing that it's already set up and arranged, it's just really helpful to encourage that true and rich embedding of the researcher within the service. It goes on nicely to the last bullet point, which is more of an administrative one, but again, it's quick admin so that the embedding can happen immediately. Because of the funding that's available, it's only going to be a short amount of time that the researcher can be within the service. And that you don't want to spend that time thinking about honorary contracts or laptops. So it's a very small thing, but just to highlight that we found, getting those processes from our side to be as speedy and as possible really helps the placements. So as soon as they get in, as soon as that funding and the date begins, they can go right into the service and begin embedding, begin attending those meetings, begin meeting people. And that was my last slide. So thank you. I've left my email address here as well if anybody would like to hear more about the placements. Thank you.
Thank you very much indeed, Becky, and thank you to the three of you for your presentations. There was a question around, will the slides be shared? So I can confirm that there will be a recording of this webinar, which will include the slides that will be made available by the Council after today's webinar. So this is now time for questions. So please do feel free to post questions in chat or to ask questions directly. But I'm going to invite Ishant Arora, who's asked a question of Nikki in terms of what perhaps some of the greatest challenges have been in terms of bringing NHS stakeholders around the Impact Accelerator unit. Whether you have any reflections on that, Nikki?
Yeah, I think getting people just to understand what it really is initially, and to convince them that it isn't going to create any more work for them, because understandably people are under a lot of pressure. Mm-hmm. And I think that the most important thing is that we work hard to support people in understanding what the IAU is, but also understanding what their big problems are at the minute. And how we can bring those two things together. So yes, I'd say that was one issue. And I think, almost we're in a bit of a brutal place within health and care at the minute. And to allow people to understand this isn't money that's being taken out of the system as it stands. This is small amounts of university money and small amounts of research money that kind of go to supporting this, so that, you know, it's not as though this is being offset against some of the way that they want to use their finances as well. So I think there are a couple of the things that immediately come to mind.
Thank you, Nikki. I'm going to ask a general question. I mean, but both you and Yanis have alluded to it, but the sort of question around sustainability. So within your IAU model, there's the sort of top slicing of NIHR grants to provide some opportunities for sustainability. I wondered what the sort of relationship between the IAU and other pieces of the architecture, like the ARC, for example, might be. How has that played out regionally?
Yeah, and that's a great point. And actually, so we're also partnering with the ARC as well. So there was a recent call for ARCs who already funded, so ring fence money, to determine how they wanted to extend and expand their knowledge mobilization activities. So our ARC West, decided to partner with the IAU and use the IAU as almost a hub for the researcher in residence model, actually, that Becky is talking about, but actually also for knowledge mobilization fellows. So effectively people from within the system, so it might be a practice nurse, might be a GP, who act as I guess the conduit for how we get that evidence into practice. So one of the examples I showed you earlier, the ADAPT study that had materials for people from South Asia living with dementia, a practice nurse and a research nurse worked with the local community to actually embed those resources within our pathways, and now nationally at Arden's level as well. So yeah, that's one way that we partner. And of course, with the iteration of the ARC West 2 or ARC 2, then hopefully that will continue to extend as well in the next iteration.
Thank you. Yanis, I was going to invite you to reflect on sustainability. We talked about an anchor institution of with considerable scope and scale. What are your challenges when you think about the sustainability of the anchor institution model?
There are two challenges, I think, Chris. The first one is the constant change in the NHS, and especially the current one. Because if you think of the level of funding we received, which was godsend, but it has an end. Yeah. You would think that it would be great to actually have a similar type of funding. At the moment, nobody knows exactly where to go, which door to knock actually to get something similar to this. And it would be very difficult to actually achieve the same level of funding. We need to be realistic. At the moment, we, in one or another way, we actually pay the salaries of some of the salaries for 33 people in the hub. That if we manage to replicate this, that would be incredible. But it is not, I think, possible in the situation that we are now with structural changes within the NHS. Not at least in this way. So what we are doing, what we have done, is that we allocated an amount of the money that we were given by the NHSC to have some dedicated time, dedicated people to write bids that are of that caliber. But as we all know in this call, it is not the easiest thing to actually get a program grant with the NIHR, or even a development program grant with the NIHR or MRC grant. But this is the plan for now. The plan is to actually keep applying, and we have dedicated some time and resources to do that.
Thank you. I'm just going to check whether I've got any more questions in the chat. I don't think we've got any more from the floor. I think the three of you have highlighted what I'm going to sort of characterize as ingredients for success. It's going to be hard for me to summarize all of them, but because there have been quite a few, but I am going to invite each of you to sort of reflect on what your top 3 key ingredients for success might be. But certainly some of the themes that I've heard listening to the presentations has been that sort of ability to connect across organizational boundaries and to build those connections, the importance of currency and credibility by focusing on real world issues. I mean, that those, and I think also shared governance, that's another theme that's come through the 3 presentations. But I'm going to invite, I hope I haven't made that more difficult by hijacking 3. But I'm going to go to Becky first and give you an opportunity perhaps just to summarize for us what you think the sort of key ingredients for success of the researcher in residence model of partnership working might be.
Thank you. So I think one is perhaps a role that I hope the ICB plays, because obviously, so there's the services that are hoping to find the academics themselves, and then we sit in the middle as the facilitators. And I hope that we play a role of driving the process forward. I think one success is somebody taking ownership, which obviously happens naturally, but I think when you have that, it really helps to keep the momentum going and keep things moving forward. The funding, obviously, one thing that we are trying to do more and more, which we have done, is support longer term research and residence posts. And obviously, as all the speakers have touched upon, a lot of it comes down to funding, but I think that that's one of the key ingredients to success. And also some that I mentioned, if I was going to pick one from the last slide, I think, again, the commitment that I've mentioned about including the academics in the ongoing working groups and meetings. So I guess that also comes back to my earlier point of ownership. If you have somebody driving that forward, and perhaps that's a helpful role that the ICB can play, but with input from the services, I think that's just one of the key ingredients. And it really is a good measure of a successful project and a successful partnership, because it tends to be those ones where we have the researcher or the service come back to us and say, is there any chance we can extend this because it's been so wonderful?
So embedded academic engagement, clear ownership and leadership driving the programme forward, and sustainable funding. Can I ask a very practical question around where the funding for academics? Do you have some researchers in residence who are academics from the university spending time in these partner organisations? And if so, how are they funded?
Yes, exactly. Yeah. So our research capability funding, so the Integrated Care Board's Research Active NHS, so we're eligible to receive research capability funding. We've got lots of details on our website about how we spend our research capability funding, and one of them is the research and residence model. So we have a set amount of funding with some flexibility. So the idea is that that covers the academics' time to come in and be placed within that service, so they will still be employed by their university, but it ring fences a bit of their time to actually embed within the service.
And you highlighted a number of important impacts from some of the projects that have been supported that absolutely have currency for our academics as well.
Exactly.
Thank you. I'm going to go to Yanis next and ask you to reflect on your top 3 ingredients for success.
Yes, thank you, Chris. I think we never forgot in our university that you work with people, no matter what the commissioning body is called, is really people behind it. And we have had, at least in my case, I've been with the university now for 13 years. Some of us for 15. For the past 15 years, we have been working with people within the trust, with people within the primary care settings. And these were the people who were really key in establishing trust between the organizations. Because what we were trying to do was actually quite novel. We were asking a new commissioning group to trust us to run the research and innovation agendas for them. And of course, it wasn't, as you would expect, it wasn't the smoothest of journeys to begin with. But we did establish that trust via different ways. One of them was to involve people with whom we actually had long-term relationships, working relationships. We funded some of the work that we did. We actually the ideas came from the providers. So the university became the funder rather than the NHS becoming the funder of the university. So we did a few things to establish that trust between the university and the new commissioners. That worked really well for us. The common governance, as I mentioned, helped a lot, and we started this from day one. We didn't bring them in when we actually realized, it's not possible to do X, Y, and Z. We'll actually bring you in at the beginning, let us know what's important for you, let's see what the priorities are, let's work on those. And the last one, I think, Chris, is to provide, as much as possible, to provide solutions without asking for a significant investment in terms of time. And we asked for £0 in 3 years from our local commissioners. We actually provided some funding for research to them. And we provided a certain set of solutions rather than asking them for any sort of input.
So that common governance piece in sort of managing and delivering expectations, I guess, that focus on, am I right in saying low-hanging fruit? So, solutions that are addressing important issues that can be delivered within the context of the initiative. I just wanted to focus on the relationship side. I mean, that's where you start, and that sounded really important, Yanis. And I wonder, in terms of the context for your case, for your example, rather, for the Anchor Institute, whether those relationships had been established, and so they were a firm foundation for this development, or actually whether you needed to connect them through this process, and how that happened.
The system wasn't ready for such collaboration, and because of the work that we do in EPIC, where the East of England Partnership for Innovation in Integrated Care, we know that this was across the board. It took some time to establish that trust. Nevertheless, the universities who followed up previous trajectories and brought in people that they already had existing relationships did much better than those who didn't. Because you may decide to embark on a completely different adventure with the NHS, with new commissioners, that would actually affect the level of trust between the organizations. What we did is to actually, do everything probably new and novel and to support innovation. But at the same time, we had those friendly faces in the board, and we through that we managed to actually establish the trust and the connections much easier and much sooner, I think.
Thank you. And Nikki, finally over to you, just for your final reflections on ingredients for success.
Yeah, thanks, Chris. So I think I absolutely agree with Yanis, and trust is my number one, and it takes time to build that trust, and it's kind of baby steps over a period of time. But I think just building on that as well, it's also about shared values that help to build that trust, because I think it's possibly from the university side of things, it could be easy to have a quite a different driver that's about the benefit for a university, whereas you have to be aligned to, yes, benefit for a university, but the whole system as well, and that almost that kind of social responsibility that you have as part of a university. So I'd say that would be one. Directly related to that is to actually kind of deliver on what you said you would do as well, because that in itself builds trust. And if you want to perpetuate that relationship, then actually people do need to see something coming out of that relationship, something tangible, and something for all partners as well. It has to be a shared and mutual benefit. And then I think that the last thing would be for everybody to appreciate the time it does take for these things to happen. You know, you can't look to set a unit up, you know, this month, and then suddenly next month everything is, you know, is changing and so much better. It does take time, and I think people really have to be aligned to that, just taking a little bit of time before you really start to reap the benefits of the partnership.
Thank you. So I heard clearly, I think, sort of authenticity running through your summary there, authentic in terms of values and delivering on that on the purpose, you know, on the mission of the accelerator unit. But I think that mutuality in terms of benefits for all constituent parts of the unit is really key. And of course, we in universities have very different key performance indicators to our service partners and the like. So finding that common ground, and I think you mentioned the word civic purpose, or somebody mentioned civic purpose, which really resonated with me. So we are coming towards the end of our time together this afternoon. I will just do a final check that we've got no more questions in the chat. We haven't. I will just give colleagues on the call an opportunity to raise their hand in a digital way. Oh, I'm not sure that came out correctly, but you know exactly what I mean. So let me just draw things to a conclusion by thanking particularly our three panelists for coming along, sharing your wisdom, your insights and your expertise this afternoon. Very much appreciated. I know that if we were in the room, you would be hearing applause now, but of course we're on virtually, so please just reflect on that virtually as well. But I would also like to thank those colleagues from our partner organisations and system colleagues who've joined the webinar this afternoon. Your time has been much appreciated. It's been good to spend some time with you this afternoon, thinking on what I think is a particularly important topic for our sector as we seek to find new ways that really crystallise the value that we add to our health and care systems and the wider economy of the UK. So thank you and have a good afternoon all.